My name is Solange Peters. I'm working as the head of medical oncology in Lausanne, in Switzerland. I'm also the current ESMO president. I had the chance after COVID to be president for an additional year, for 3 years, until the end of this year. And I'm also the, I would say, initiator of an important initiative in ESMO, which changed ESMO about diversity, the Women for Oncology. We've been working a lot for diversity in ESMO. Yeah. Thanks a lot for the question. So it's quite important for me, first of all, to recognize how difficult it is sometimes to not to be able to be present in a congress. Not that the data cannot be seen, because we will share the data very soon. For the Chinese doctors, it's important for them to know that after 3 months, the ESMO members can see everything, and after 6 months, it will be completely accessible to all. But in 3 months, the data will be on the website. But to know before, I think the highlights are mainly what we tend to present and select for what we call the presidential. We have a very strong degree of selection process of scrutiny to select what is presidential, because for us presidential means it has to be practice changing. So when you come back home, you change the way you work, or maybe the way you behave with your environment. So the highlights are the presidential session. So look, listen, read about the presidential sessions. There will be a lot of articles and journalists, because they really bring to you what makes you change your practice. So that's basically the definition. There are many highlights in this presidential. I would like to quote 3 important, because they were presented yesterday. First of all, the role of pollution, which can be interesting and important for some European cities, but also from some Asian cities. The fact that pollution can be the source of cancers in never smokers, and particularly lung cancer with EGFR or KRAS mutations. And yesterday, Charlie Swanton could show the relationship between pollution and lung cancer, but also the mechanism behind, and could explain how to potentially act on it, of course, change the environment and protect the environment, but also in terms of biology. So this is, to me, the phenomenal abstract of the meeting, because it speaks for sustainability initiatives, but also it speaks for high-level biology, explaining sometimes what you see more than we do in Europe, but these people with lung cancer who have never smoked, right, which is the most terrible situation. So this is for you, the abstract to go through, because I'm sure it's the beginning of a new explanation for lung cancer, right? The second abstract yesterday was the use of T-cell therapy, infiltrating lymphocytes. You take a tumor, you take out of the tumor the lymphocytes. Of course, you grow them a lot, and you reinfuse it to the patient after chemotherapy. It's something we do a little differently with CAR T cells in leukemia, for example, or in lymphoma. But this is melanoma, and this is the lymphocytes which are found in the tumor. So John Hannon did a European trial comparing this TILS therapy to the usual ipilimumab in second-line melanoma. And he could show a major improvement in disease-free survival. So, of course, it's very good for melanoma patients, but it's also a completely new way to treat patients, right? And it might be expanded to other disease types, to other strategies. So it's like a new class of drugs, if you want. And last but not least, yesterday we had gamma secretase inhibitors, so a new class of drug too, which was used in a rare tumor, desmoid tumors, which usually has no standards of care. So always showing to the community that we need to address now clinical trials to these patients who have orphan disease, rare disease, and this is feasible thanks to international collaborations, right? So this is probably very important landmarks. Today and tomorrow, at the presidential, we will see, for example, melanoma data, neoadjuvant or adjuvant. So it's very important for immunotherapy, so we'll have the answer. We'll see renal data, neoadjuvant or adjuvant, how to make it better in the adjuvant setting. And maybe should we combine more drugs? You can imagine an IO, anti-angiogenic, TKIs, how can you combine more in renal cell carcinoma? You will have the answer in the next presidential session. And last but not least, the lung. For the first time, we have the randomized data of KRAS inhibitors. When I started oncology, KRAS was not actionable, I was told. Now we have KRAS inhibitors, KRAS G12C inhibitors, and they are compared in second line to docetaxel, showing superiority. And last but not least, a trial which I really like, addressing these patients who are always excluded from clinical trials. PS223, are the patients with PS1 but elderly with comorbidities, right? What we call platinum ineligible. And in this trial, we try to test how atezolizumab can be used as monotherapy as compared to gemcitabine, vinorelbine, the single arm, the single agent strategy we usually use, showing a benefit in everything: OS, PFS, response rate, quality of life. So really, meaning diversity. It's also about patients who are frail and fragile. The PEARLS trial, the KEYNOTE-091 trial, is one of these two adjuvant trials which has delivered results today. It is randomizing patients with completely resected non-small cell lung cancer with an optional chemotherapy. It's optional in PEARLS. They randomize this patient between 1 year of pembrolizumab or 1 year of placebo. There are two dual, as you said, dual co-primary endpoints. Dual means that if one of both read positive, the trial is positive. The first one is disease-free survival in the whole patient population. The other endpoint, probably the one we expected to be the easiest, is DFS in high PD-L1, more than 50% TPS score population. While at the first presentation we could see a benefit in DFS, statistically significant, clinically meaningful in the ITT population, very surprisingly, we could not see the same benefit in the high PD-L1 population, which was supposed to be the easiest to reach. And tomorrow I do a presentation to try to explain why. So we tried to look why this specific population was not improved. So first we looked at patient characteristics. Are they different between the ITT and the high PD-L1? The answer is no. Baseline characteristics are the same. Second, is the toxicity different? More or less? No, the toxicity is the same. Third, is the drug exposure different? No, the drug exposure is the same. So we had to go back to Kaplan-Meier curves. And the good news is pembrolizumab works as expected. The more PD-L1, the more benefit. So you had this incremental in terms of Kaplan-Meier curve in the high PD-L1 subgroup, as expected. The unexpected, the surprise, is in the placebo arm, the high PD-L1 were also doing better. And this is counterintuitive and even against the data, because until now what we know is that if you use chemo, if you use nothing, usually PD-L1 is not prognostic, and if anything, it guides a poor prognosis. It doesn't make it better, it does it worse. So it might be a kind of a spurious combination of factors making the overperformance of the control arm, specifically in these high PD-L1 patients. So the explanation is about this overperformance. Therefore, the conclusion of PEARLS is to say pembrolizumab is a valid option across all subgroups of PD-L1 patients. Thanks a lot. There are plenty of trials, as I discussed in my talk, plenty, and I'm happy to share the slides of whoever writes me an email. I did review what we have about, we use ctDNA in the specific context of what you call minimal residual disease. So in most of the time, you use it after surgery to try to classify patients between residual disease, yes or no, by looking in the blood. Most of the tests we use today, but not all, are what we call tumor-informed, meaning that at the time the tumor was present, there was a whole exome sequencing or a whole genome sequencing performed comparing to blood to try to see the signature of the tumor. And later on, you try to look at this signature later on down the road. It can be genes known, a set of genes which are known, or it can be personalized signature, specific mutations of the tumor. But that's how we do. We try to follow and to know if the patient has still the signature, the molecular signature after surgery. So we have now a dozen of trials showing that if you try to understand what happens to the MRD positives versus the MRD negative, very obviously this is prognostic. If you are MRD positive, you do worse. That's for sure. What we still haven't shown are two or three things. The first thing is what methodology to be used. The second thing is how to improve sensitivity. Because in all of the trials we've been seeing, some patients who relapse were MRD negative, meaning that we are still not able to detect MRD in many patients. So that's really a big problem. And third is it also predictive? Meaning if you detect MRD and you add the treatment, are you able to revert the course of the patient? Will you improve the survival, or is it too late? And anyway, whatever you do is not useful. I'll take the example of IAM Power 10. In IAM Power 10, when they have done surgery before starting atezolizumab, they did this MRD with a very nice technique. They did this MRD. So when you look, of course, the MRD positive do worse than the MRD negative. But look at the MRD negative. Still, a lot of them relapse. Almost 25% of them relapse. They're not supposed they are MRD negative. And importantly, the atezolizumab has still a benefit in MRD negative, meaning that the same benefit in negative and in positive, by the way, meaning that it's not predictive of an additional treatment. So prognostic, yes, predictive, still not. So to answer your question, we did better sensitivity, we did the establishment of predictive ability, so it is not ready to use. We need to have more trials, prospective trials or larger trials to be able to find a way to use it. It will not take a long time. It will take months or years, but it's not ready to use yet. That's the $1 million question, right? So is more better? Usually, we should not think this way. The reason why we think this way is most of the clinical trials are driven by a pharma industry. And of course, there is always some marketing issues. So usually the more is not the better. But we need to define how much is needed, right? So today we have a dilemma because you can give a short course of neoadjuvant chemo IO based on Checkmate 816, 3 cycles of chemo IO, surgery, and it's done. But you can also give surgery and 1 year of immunotherapy, which is way longer. And what will come tomorrow is the whole of that, neoadjuvant chemo IO plus 1 year of adjuvant. So the kind of a total therapy, if you want, the maximal therapy. So which one is better, neoadjuvant, adjuvant, or what we call perioperative, the whole cycle? We don't know. And I'm not sure we will have a very clear answer because we're not supposed to compare. But time after time, we will have so many data sets that I hope we will be able to decipher what is the most convenient in terms of sustainability, cost, and so on, and also in terms of potential really significant difference in outcome. Today we cannot say. So today we have to let it to the regulatory environment and the investigator. But I'm not sure that at the end more will be better. But I think we'll have to subdivide patients into risk categories. And I come back to your question about ctDNA. At some point we might use ctDNA to know if you need more. And that's where we need ctDNA, I guess. Yes, all these immunotherapy trials are challenging because we don't know if they will lead to an overall survival benefit. We've been seeing at the World Lung the overall survival early curves of IMpower10, and we could see really a signal that OS would be met in the future. So what I mean is, I think these trials need maturity, which will take 2 more years or 3 more years. But I expect that this immunotherapy strategy can lead to an OS benefit. So I would potentially think or say, wait a little bit, look at IMpower signal. IMpower10 is a signal, OS can be reached. So I would say yes, they will lead probably to OS benefit. Question is it in the ITT population or only in a subset? We have to wait for more data. But I would guess immunotherapy, as you said, based on the fact that in all immunotherapy trials, the impact was more important on OS than on PFS. So magnitude was higher on OS, the tail of the curve. So I would, if we wait enough, I hope they will lead to the same phenomenon.